Your Royal Highness Princess Mahashakri Sirinthorn, Your Royal Highness Princess Dina Mired, Your Excellencies, distinguished guests, ladies and gentlemen. It is a very great honor to receive the Prince Mahidol Award in the field of public health, which I am accepting on behalf of my many wonderful colleagues in London, the Gambia and Tanzania, without whose contributions I would not be standing here. I went to work in the Gambia, a small country in West Africa, as a young doctor, and I was in charge of the outpatients and a small ward. I soon discovered that sexually transmitted infections were a big problem, but we had no way to diagnose chlamydia trachomatis infection, which I knew coming from Europe was a big problem. We couldn't diagnose it, and at that time there was not a single publication on genital chlamydial infection in Sub-Saharan Africa. So I spoke to my mentor, Dr. Hilton Whittle, who had recently arrived in the Gambia to set up a virology research program. And I said, what should we do about this? I don't know if I should be treating my patients for chlamydial infection. He said, well, you better find out how to diagnose it. So he sent me to London to learn how to culture chlamydia trachomatis, which was the only way to diagnose the infection in those days. And we set up a culture facility in his lab in the Medical Research Council compound in the Gambia. There was a notice on the door from which I discovered that this lab used to belong to the MRC Trachoma unit. I didn't know much about trachoma at the time, so I started to read about it. I discovered it is the leading infectious cause of blindness, and it's caused by chlamydia trachomatis. And the ocular serovars are very closely related to the ones that cause sexually transmitted infections. In the case of trachoma, the infection is spread from eye to eye in populations living in poverty, by flies, by sharing of cloths, by children, siblings sharing a bed, and so on. Trachoma was a big problem in London 200 years ago. The first eye hospital in Europe, Moorfields Eye Hospital, was founded to deal with trachoma 200 years ago. As living standards improved, it disappeared from the more developed parts of the world, but remains a huge problem among poor rural populations in Africa and Asia. What happens when you get chlamydia trachomatis in your eye? You develop inflammation, which is best seen on the inside of the upper eyelid here. And these little white spots, these are called trachomatous follicles. And when more than 5 of those are seen in the everted upper eyelid, this, according to the WHO definition, is trachomatous inflammation follicular, or TF. After repeated episodes of infection, as occur in those settings, scarring develops in the conjunctiva. This process usually takes a number of years. Then, as the scars contract, the eyelashes turn inwards and scratch against the cornea, the front of the eye. As you may imagine, this is extremely painful and very difficult to live with, and eventually, of course, it causes damage to the cornea and the patient becomes blind. So what were the MRC Trachoma unit doing in the Gambia in the 1970s? I discovered they had done 3 trachoma vaccine trials. This is Professor Leslie Collier, who was the director of the unit, vaccinating a Gambian baby with whole chlamydia. Unfortunately, the vaccine did not work, and there was even a suggestion it made the disease worse. And similar findings came out of other vaccine trials in Taiwan and Ethiopia. So I spoke to the people who had been involved in those trials and discussed again with my mentor, why do we think the vaccine didn't work? So he said what he always said to me, you better find out. So we started to do some work to try and understand which might be the protective responses and which immune responses might cause damage. We found trachoma was a very big problem in this village, for example. The problem then was how to obtain funding, because the vaccine hadn't worked. The WHO had not yet launched its program for neglected tropical diseases, and nobody was interested in funding research on trachoma. However, we were lucky to come in contact with Dr. Joe Cook, a distinguished tropical disease doctor from the USA, who was in charge of the Edna McConnell Clark Foundation, a charitable organization in New York. And he agreed to fund our studies, initially looking at the immune response in trachoma. In those days, the recommended treatment for trachoma was tetracycline eye ointment applied to both eyes twice a day for 6 weeks. Now, trying to do that to young children, I think you'll agree, is challenging. And so very few people completed treatment. But at about this time, a young medical student called Robin Bailey came out from the UK to gain 6 months research experience with me. And he said, well, there's this new antibiotic called azithromycin just come on the market. And it seems that 1 dose is sufficient to cure sexually transmitted chlamydial infection. So why don't we see if it works for trachoma? So we did a randomized controlled trial in 2 villages in the Gambia, comparing 1 dose of azithromycin with 6 weeks of twice daily ointment given under supervision. We showed that the 2 treatments were equivalent, but the problem was when you only treated individual cases, they soon became reinfected. So we went back to Joe Cook, and he agreed to fund a second study, which we did in collaboration with American colleagues at Johns Hopkins University and University of California in San Francisco, looking at mass treatment, where you treat the whole community with either azithromycin or tetracycline ointment. And there were 4 villages in each arm of the trial in the Gambia. This shows reinfection rates at 12 months. And I think you can see reinfection was less common in the villages that received azithromycin. So this was very encouraging. The problem was that azithromycin was a new antibiotic. It was still under patent. It was very expensive. But by a fortunate coincidence, Joe Cook's office in New York was 2 or 3 blocks down the road from the headquarters of Pfizer Pharmaceutical Company, the manufacturer of azithromycin. So we went with Joe to talk to Pfizer and ask if they would like to donate azithromycin for trachoma control programs. And I confess I was surprised when they agreed to do this, but they did agree. And as a result of that, the World Health Assembly passed a resolution in 1998 calling for the global elimination of trachoma as a public health problem by this year, 2020. How was this to be done? The so-called SAFE strategy, surgery to correct those interned eyelashes, antibiotics, mass treatment with azithromycin, encouragement of face washing and environmental improvement to try to reduce transmission of chlamydia from eye to eye. What exactly did they mean by elimination as a public health problem? They meant that the prevalence of trichiasis, that's where the lashes rub the eye, should be less than 2 per 1,000 in adults, and the prevalence of follicular trachoma less than 5% in children aged 1 to 9 in every district in the world. So 20 years ago, we were fortunate to obtain funding from the Wellcome Trust to look in more detail at the SAFE strategy. And we were fortunate to recruit 3 wonderful PhD students. This is Matthew Burton, who was a trainee ophthalmologist, who did the definitive study to show which is the best operation to do for trichiasis, which led to a change in the WHO recommendation 2 or 3 years ago. This was Paul Emerson, an entomologist who studied the impact of fly control in the Gambia and is now director of the International Trachoma Initiative, which oversees the azithromycin donation program. And this is Anthony Solomon, an infectious diseases trainee who showed during his PhD that it was possible to eliminate ocular chlamydial infection from a village with 1 round of mass treatment if coverage was high enough. And Anthony is now in charge of the WHO Trachoma Elimination program in Geneva. So how are we doing? Well, more than 850 million doses now of azithromycin have been donated. Pfizer have agreed to continue donating it for as long as it is needed. The number of people at risk of trachoma has been reduced from 1.5 billion to 140 million, a 90% reduction. The number of people needing surgery for trichiasis has been reduced from 7.6 to 2.5 million. 9 countries have been validated so far as having achieved those WHO elimination targets, and 4 other countries report having met the target and are awaiting validation. And I'm delighted that this includes the Gambia, where we did those first studies. So I'm afraid we're not going to achieve our target this year, but if progress continues, as at present, there is a very good chance we will achieve those targets globally well before 2030. One other thing we discovered when we started the trial on mass treatment with azithromycin, we found it had additional benefits as well as the impact on trachoma. And our American colleagues noticed in Ethiopia, this was a few years ago now, that in communities which received azithromycin once or twice a year, there was a reduction in all-cause under 5 mortality. So we completed a trial which was published in 2018, in which we looked at the impact of twice-yearly mass treatment with azithromycin on all-cause mortality in children under 5 in 3 African countries. And this was a 2-year follow-up study, and at the final follow-up after 2 years, there was overall a 13.6% reduction in all-cause under 5 mortality in those communities which received azithromycin. And if you look at it by age group, the biggest impact was in babies aged 1 to 6 months, in which mortality was reduced by 25%. Your Royal Highness, I am delighted that the increase in funding and drug donation for the control and elimination of neglected tropical diseases over the past 10 years, using strategies in which community health workers are trained to identify cases and give treatment, has had a significant impact of the most neglected populations in the world and is already accelerating progress towards universal health coverage. Long may it continue. Thank you.